very good evening. Thank you again. It's been a pleasure. So I'm going to talk to you about OCT angiography in white dot syndromes. Now, with the increasing imaging modalities and the knowledge that we have gained over the past several years, we prefer nowadays no longer to use the term white dot syndromes, but rather call them by individual entities. So what I would be covering in my talk would be punctate inner choroidopathy, MUDES, MPE, multifocal choroiditis, and serpiginous choroiditis. And there are two more to fill in, that is the POHS and birdshot. And since we don't see them much in our subcontinent, I'm just going to avoid speaking on those. So let's directly jump to our case one, which is a 24-year-old Asian Indian girl. And she complains of multiple scotomas, and she's myopic. And if you look carefully, you have lesions here in the right eye, right in the center, and you have multiple lesions here in the perifoveal area in the left eye. If you look at the OCT passing through the lesion, it's very characteristic here, where you have the disruption of the RPE, and you have a lesion here which is mound-like, and it is actually going on to the outer retina. And if you look at the left eye, again, you can see here the OCT is very characteristic. You have an intact Brooks membrane. And looking at this OCT, we're quite comfortable in terming this as punctate inner choroidopathy. And you have this subtle outer retinal disruption. This is the autofluorescence of the patient. But what's very interesting is we've seen this patient in November 2017 and again on June of 2018. And as you can see on the OCT, there's really nothing much, no much appreciable change over this period. This is what she has in June of 2018. So on the OCT angiography, you can see this kind of a network here. And this is the patient back to us in about 2 months in August. And here you can appreciate the presence of retinal heme, and that's causing the blocked signal on the autofluorescence. So if you look at the OCT in August, you have the fluid coming up. And I think OCT angiography has a very important role in PIC, and I do believe that a large proportion of patients of PIC, probably more than 80%, harbor some kind of neovascularization within the lesions. And so I find OCT angiography extremely useful in following up patients of punctate inner choroidopathy. So that's the learning lesson number 1. Let's move on, and this is a case of a 32-year-old male with bilateral diminution of vision. We're looking at the left eye here, and at the autofluorescence shows you the active disease. It's serpiginous-like choroiditis, and this is the right eye of the same patient. If you look at the combined fluorescein and ICG, and focus here on the ICG, and you see the central area here where you have hypo, and it continued to remain hypo in the late phase, suggestive of choriocapillaris ischemia. So if you look at the OCT angiography, you can see exact co-localization of the ischemic area that you see on the ICG with the OCT angiography, and this is very useful as a baseline evaluation of these patients. So in patients with SLC, you see this inner ischemia, and if you have the accompanying structural NFAS, you can see that this is not a signal loss really, because it exactly corresponds to your ICG as well. Now, if you see this patient has been treated, and 3 months later, if you look at the follow-up ICG here, you see very minimal sort of a damage here, which is residual. And I'm just comparing the baseline ICG with the ICG at 3 months, and you see a significant resolution here. And this is what is exactly demonstrated by your OCT angiography. So you have very minimal sort of choriocapillaries damage, which is present at 3 months. And so the learning lesson number 2 is that healing of lesions in multifocal type of the serpiginous choroiditis is accompanied by reduction in the choriocapillaries flow void area. And this manuscript of follow-up is currently under review in Retina, where we have shown that if you have a very small lesion, less than 0.1 millimeter in size, they are the ones that tend to resolve with minimum flow voids. And so we need to be really aggressive when these lesions are very small. And this is actually the follow-up over 3 months using OCT angio in this particular patient. Now, this is a patient of placoid disease. Although that's not my topic, it's one of the later talks. But here you can see at the baseline ICG here on top showing you the ischemia, which corresponds with the follow-up, the baseline OCT angiography. And this is the follow-up ICG showing the healing, which is seen again over here on the OCT angiography. But you can see this area here has choriocapillaries atrophy, and so you're able to see the underlying choroidal vasculature. 21-year-old male, no previous history, and he's seeing spots in front of both eyes. The OCT and the ICG, I think, are very characteristic of AMPE here, where you have the ellipsoid disruption, photoreceptor disruption, and you have a placoid lesion which remains hypo to hypo on ICG. And in these patients, you find OCT angiography very characteristic. Again, there is a very good co-localization with the ICG. And in these patients, you have the confluent pattern of choriocapillaries involvement. And this is the learning lesson number 3, that in AMPE, you have predominant involvement of the choriocapillaries. A 51-year-old Caucasian woman with blurring and spots in her eye, and you can see this on the ICG, you have these hypospots which are coming up near the superior arcade as well as inferiorly. And you see actually something which is more prominent on the autofluorescence. You have a lot of these spots, including in the nasal retina. So it's mudes, and these lesions are very typical here, and they're usually hypo to hypo on ICG. But again, on ICG, some of these lesions may be ISO to begin with. The OCT shows this characteristic disruption here of the ellipsoid, and it often extends to the outer retinal layers, and you have an intact choriocapillary. So if you look at the OCT carefully, you have a very intact choriocapillaries, and that's very important here. And if you look at the OCT angiography, you can see here these changes that come up on the ICG do not reflect on the OCT angiography. So this is a very important learning point here, that on OCT angio, you do not have any alteration in the choriocapillaries in mudes. And a very interesting imaging here, this is another patient with mudes, and if you do a blue peak autofluorescence, you find hyper in these patients, and these lesions appear to be hypo on near infrared autofluorescence. But there is nothing on OCT angio. So the learning lesson number 4 will be the OCTA in mudes shows intact choriocapillaries, and actually there's a talk on this in this session, and I'm sure Dr. Abhilasha will talk about that this helps us in determining the pathophysiology of this condition. So the summary, in PIC, I would use OCTA to look at the CNV. In multifocal choroiditis, I would look at it to demonstrate the healing of the lesions. AMPE, again, it shows you a very good co-localization. And in mudes, OCT angiography really confirms that there is no choriocapillaries involvement in this disease. Thank you.